Can we move to the next question then?
Yes, sir. Good evening, sir. My presentation for today is first topic is anesthetic management of aspirated foreign body in a 2-year-old male. Foreign body aspiration is one of the leading causes of death among young children. Most common age group is between 1 to 3 years of age. Boys are most commonly affected than girls, and most deaths are due to complete airway obstruction. The most common cause due to this age group is between the 1 to 3 years of age. Many children put their objectives in their mouth while running, and they have less ability to chew food in the absence of molarity. And the most common aspirated object is food in which peanut is most common. And the presentation is variable, and it causes early and late presentation, and diagnosis is difficult. And it depends on the size and shape of object in it and the site of object within the airway. And the trachea, the main bronchus, is the most common site of the foreign body logic. And early presentation presents with severe acute upper respiratory obstruction. And though the well pink looking child, often with a cough, is most commonly the presenting symptom. And late presentation presents as signs and symptoms of secondary to lower respiratory tract infection and present as pneumonia. And most commonly, the foreign body loss is on the right side. And careful history taking is important regarding the diagnosis. And the sudden onset of choking followed by coughing and wheezing is most common. And object the batteries is most common. They have a higher degree of urgency due to the corrosive nature. And history of persistent cough also is most common. And we have to look into signs of cyanosis, stridor, intercostal and sternal recession, and decreased conscious level. And these are consistent with the upper airway obstruction. And history of voice change or barking cough or laryngeal edema also suggests the foreign body and upper airway obstruction. And the late presentation, the signs of pneumonia will be presented like fever, cough, tachycardia, tachypnea, and focal chest signs. And the special investigation should be looked for us apart from oxygen saturation level and chest X-ray, AP view and lateral view to be done. And the film should cover the entire neck. And majority of the inhaled foreign particles are organic material only. And most radiographs, especially, will demonstrate an abnormality, especially in first 24 hours. Even absent of any abnormality also doesn't exclude the presence of foreign body. And the most frequent finding seen in the chest X-ray is gas trapping due to the ball valve effect of foreign body due to respiration. And mediastinal shift can be seen, atelectasis can be seen, lobar collapse or consolidation can be seen. And management strategy, it can be immediate basic life support management. If the child is acutely unwell, they should be assessed and managed as per the choking child. If we have to assess whether the child has an effective cough and whether the child is crying, talking, or not silent and breathing between coughs. If so, we should closely observe and encourage to cough by themselves. This is the best maneuver. And if no effective cough, we have to assess whether the child is conscious or not. And the rescuer may intervene with 5 back blows followed by 5 chest thrusts. This chest or abdominal thrust, which is commonly used in older children, they have the risk of dislodging the foreign body and worsening the obstruction. And next to it, if the child is not consciousness, first preference to airway, breathing, and circulation as per the BLS guidelines should be followed. And subsequent management strategy, most children who reach with hospital with a foreign body have an effective cough, and we have to assess the child and arrangement to transfer to OT immediately with appropriate skilled senior personnel and arrangement of flexible and rigid bronchoscopy should be done with under general anesthesia. And which is the gold standard technique is this, the flexible rigid bronchoscopy. We have to arrange an ENT or pediatric surgeon for this. And communication between all the medical personnel and senior medical staff, and two anesthetists should be done. There one should be a pediatric anesthetist, and the technique of anesthesia, we have to ask the fasting status, which is 6 hours for solids and 2 hours for clear liquids, which decreases the aspiration. But even in emergency, we have to transfer to OT without full fasting details. Inhalation induction can be done with spontaneous breathing despite a potential full stomach. And regarding pre-medication, it is better to avoid sedative pre-medication since it will improve the perioperative respiratory drive and to avoid further dislodgement of the worsening of the obstruction. And regarding anticholinergic pre-medication, it will many avoid using the atropine and glycopyrrolate, and but it also reduces the RV secretion and it decreases the vagal induced bradycardia. And regarding the medical therapy, preoperative chest physiotherapy has been followed in the past, but it also proven to dislodge the foreign body more proximally and it will worsen the obstruction. So currently it's not being followed. And those presenting late with symptoms of pneumonia can be given a course of antibiotics, and to prevent or treat laryngeal edema, steroids can be given. And I insert a cannula in a distressed child even with difficult veins after the inhalation and induction of anesthesia. And regarding the induction of anesthesia, it is done under inhalation with either sevoflurane or allophane in order to maintain the spontaneous ventilation. Allophane is cheap and smooth, and induction is easier to maintain depth with spontaneous ventilation, but there is a risk of cardiac dysarrhythmia. And regarding sevoflurane, it has a relative stability of cardiovascular system, and we can also use a combination of nitrous oxide and sevoflurane, which has a faster recovery and decreased incidence of post-operative nausea and vomiting. And also a local anesthetic spray with 4 mg per kg lignocaine can also be sprayed onto the vocal cords and hypertrophy, which will decrease the target response to bronchoscopy. And regarding superior, since it will decrease the chance of distal movement or dislodgement of foreign body, and it will less likely to worsen the heart trapping, which is most common with the paralyzing technique, which is ventilative forced pressure, which will worsen the distal obstruction or. And regarding the perioperative complications of anesthesia, and regarding the RV-related complications, laryngeal edema is most common, and complete airway obstruction, secondary to dislodging of foreign body, and a failure to remove the object. And regarding breathing, hypoxia, hypercarbia, coughing, regurgitation, and aspiration of gastric contents, pneumothorax, and pneumonia. And regarding circulation, cardiac dysarrhythmias and cardiac arrest is most common. And regarding neurological, seizures is most common, secondary to hypoxia or hypercardia, and it can also lead to death. And the foreign body can make it become snapped and dislodged with the cords or larynx, and it can lead to severe complete airway obstruction. Due to bronchial edema of the affected site, the object may fall into the good lung. It may also affect the gas exchange. If the object lodges in the trachea, the foreign body can be retrieved rapidly. If this is not possible and severe desaturation can occur, foreign body is pushed down to one bronchus to allow some gas exchange. Sometimes, occasionally, an emergency tracheostomy may also be required in many of the cases. And in post-op care, it depends on the clinical state of the child. And chest X-ray should be done to rule out pneumothorax or any other abnormality. If the child is clinically well, the child can be discharged on the same day of surgery. And delayed treatment consequences should be treated as per the pneumonia. And my second topic is regarding the caudal space anatomy and the indications and technique of caudal blocks. Anatomy of caudal space. The sacrum is in the shape of an equilateral triangle with the anatomy is the two posterior superior iliac spine with sacral hiatus, which is formed by the fusion of articular and transverse causes, which forms the intermediate and lateral crest. And the sacral hiatus It is is formed by the caudal end of the median crest created by failure of the S5 lamina to fuse, which is surrounded by the sacral cornua, which are the remnants of inferior S5 articular process, which pay the coccygeal cornua. And after passing the sacral cornua and which identifies the sacral hiatus, which is leads to successful caudal block. And the sacral hiatus is inverted U shape covered by a sacrococcygeal ligament, which is in continuity with the ligamentum flavum, and sacral canal, which is in continuity with the lumbar epidural space. The sacral canal contains the nerve roots of cauda equina, which lead it through the anterior sacral foramina. And dural sac, which ends at S2 in infant and S3 in child and adults. And dural puncture leads to the extensor spinal anesthesia. And contents of the caudal space is lumbar epidural space, fat and epidural veins, and dural sac nerve fibers. In children, epidural fatty tissue is looser and more fluid, favoring the local anesthetic diffusion. And regarding the indications of caudal block, abdominal, urological, orthopedic surgical procedures located in subumbilical, abdominal, pelvic, and genital areas or lower limbs where the post-op pain does not require prolonged strong analgesia. Example, icospadias, orchidopexy, umbilical or inguinal oniorrhaphy, and clubfoot surgery. And also it is used in daycare surgeries. And eye, abdomen, and thoracic surgeries can also be used. And caudal catheter can be inserted in the eye, abdomen, and thoracic surgery. And regarding the technique of anesthesia, we have to obtain the consent of the patient and the parents, and induction of a general anesthesia with airway control. With the induction of anesthesia in the lateral or ventral position is done, and the hips is flexed to 90 degrees, and the sling disinfection is done since in close proximity to the anus. And according to the child size, needle diameter and length, the sacrococcygeal penetration, and it decreases the risk of vascular puncture and sacral perforation. And a stimulated needle is used, which avoids the risk of subcutaneous tissue pouring and the risk of epidural cutaneous cell grafts. And regarding the puncture, and we have to see the bony landmarks of sacral triangle and the two sacral cornua, and move the fingertips from side to side and puncture between the two cornua, and the needle oriented 60 degree to the back plane and the 30 degree to the skin surface. And the needle is oriented ventrally and parallel to fibers of the sacrococcygeal ligament. And a perceptible pop will be felt when we cross the ligamentum flavum. And after crossing the ligamentum flavum, the needle is directed 30 degree to the skin surface. And it is advanced few mm into the sacral canal. If we hit the bone and the needle is moved slightly back, verify absence of spontaneous reflex of blood or CSF, which is more sensitive than the aspiration test. And insert local anesthesia without resistance slowly at 1 minute. And any subcutaneous bulging at injection site indicates the needle displacement. The needle can be displaced due to marrow resistance or a subperiosteous ligament bulge or a decoy hiatus or any damage to pelvic structures like rectum. And the puncture success is confirmed by the whoosh test or swoosh test, where there is injection site auscultation with a 2 ml of air. It is a whoosh test. And later saline was used, so it is called a swoosh test. And anal sphincter contraction in response to electrical nerve stimulation on the puncture needle is noted. And regarding the catheter insertion, and a single shot catheter can also be extended as a caudal catheter to prolong the analgesic administration in post-op periods. And the advantages are catheter-related bacterial colonization and catheter displacement. And regarding the Armitage regimen, the volume of 0.5 ml per kg of local anesthetic, most commonly bupivacaine is used, and the dermatomal level is sacral level indicated for circumcision, and a 0.75 ml per kg inguinal level, and it is used for inguinal amniotomy surgery, and 1 ml per kg for lower thoracic T10, and it is used for umbilical amniotomy, and 1.25 ml per kg in thoracic level and also used in orthopedic. Thank you, sir.
Now I have a few questions to you.
Yes, sir.
First of all, with regard to the foreign body aspiration in the children, what are the challenges that you face in this? I think I have given the age of the child also in the question, isn't it? Your mic is not on.
Yes. Pediatric age group, sir.
Pediatric age group.
Yes, sir.
Then
They are more prone for desaturation, sir.
okay.
And
Question says,
yes,
discuss the
sir.
management of a foreign body
Yes, sir.
retrieval in a 2-year-old male
Yes, sir.
child. Okay. So first is a pediatric age group. Okay. Then
Yes, sir.
is there a possibility
Then
of
a foreign body.
full
Yes,
stomach
sir. Yes,
problem?
sir. Full stomach, yes, sir.
That's also
Fasting
to be
status.
mentioned. Because
Yes, sir.
you said peanut. Patient would have eaten a lot of peanut and suddenly one peanut after about consuming 100 grams of peanut, he suddenly aspirates one thing that can. So full stomach is another problem. Then
Yes, sir.
how can the presentation be? There are three varieties of presentation. There is a foreign body aspiration. What are they?
Choking, coughing, and
Initially, if it is a
stridor,
huge foreign body blocking the airway completely, what will happen
complete
to the child?
appearance,
It may not reach the hospital at all. It may die of hypoxia
sudden
at the
death,
site of
sudden.
accident itself. The second is partial obstruction of the airway. That child only will be having a coughing, distressed breathing, cyanosis, hypoxia, all these features, but still the patient may be conscious or semi-conscious, and it is brought as a hurried nature by the parents. Okay, and the third is a very small foreign body getting aspirated, going and lodging somewhere in the distal part of the lung, not obstructing the upper airway. So nobody notices, and gradually the child starts developing a chronic cough and develops a pneumonic features, which is not a life-threatening emergency. Okay, so these are the three categories that we have to describe. One is an acute complete blockade, which the patient may not reach the hospital at all. The second category where there's a partial obstruction of the upper airway, which causes decreased respiratory effort or gas of exchange and causing a hypoxemia and struggling in the breathing and cough and respiratory distress. Okay, so that is a particular child which poses a great challenge. And the fourth challenge is the parental anxiety here. No? Parents will be very anxious that, because the child is struggling to breathe and trying to cough it out, and they're not able to do that. And once it comes to the ER, if there are unfortunately no doctors to attend at the time, patients become more agitated, and these are the situations which lead to the fight in the hospital, in the ER room, or if something goes wrong to the child, they will blame the doctors that attention was not given in time. That is the reason for the loss of life. All those things can happen. And, have you ever had a chance to anesthetize a foreign body in a baby like this? Your training so far?
No, sir. I haven't seen.
Have not seen, because this is not
Yes,
a
sir.
very common scenario. It
Yes, sir.
goes mostly to the pediatric institutions where more experienced people are available. So general public will themselves be directed to go to the pediatric institute rather than come to an orthopedic institute like Miot and other. So you may not have a chance to see such cases in your career unless you become a pediatric anesthetist or you work in a rural center where once in a while you may get a case like this. So first thing in your theory answer or in your exam, practical exam also, these are the challenges you have to describe. One is with the pediatric age group. Second, the child may have a full stomach. Third, the child may be in respiratory distress and hypoxemia, which requires an urgent intervention. And fourth is the anxious parents who are all very tense and that they also have to be calmed, and you have to explain the whole thing to them and make sure that there is no rub between the attenders and the doctors. Okay, these are the four challenges that we have to face. And once you decide that child is going to child is in the respiratory distress, you must decide at what level the foreign body is stuck, which is causing the difficulty. So it may be usually in the upper airway only. Below the vocal cord, it may be partly in the trachea or in the major bronchi. So that is the reason for the child to have this problem. So all efforts to make sure that no aspiration happens because of full stomach, but there is no time here for you to prepare the child make the child wait for gastric emptying to happen and all those things. So the risk should be explained and adequate consent has to be got. That full stomach situation has to be explained to the parents and it should be included in the consent form. That is a very, very important criteria that they have to do. Then managing or removing this foreign body is usually done with either a rigid bronchoscope or a flexible bronchoscope. Normally, which one will be preferred? You think? Is it easy to do the flexible or is it easy to do the rigid? Most DA persons, can you answer this? Are you there, Dr. Damodaran? Anybody else who can answer? Then all the rest are primary candidates only. So usually the rigid bronchoscope is the one which is preferred. Why? Can you at least make a guess why it is preferred rather than the flexible one?
Bleeding will be less. Traumatizing the airway would be less.
Which one? Rigid or flexible?
Rigid will be.
Rigid causes more trauma or less trauma?
Less traumas.
Flexible causes more trauma. Right? Normally, which one you are using nowadays if you want to intubate a patient?
Flexible.
Flexible. So which one will be more traumatizing?
Flexible only.
Rigid is conventionally used because most of the instruments which are used to grasp the foreign body and pull it out, they go very easily inside a rigid bronchoscope rather than whereas in the flexible bronchoscope, we have to go through the working channel, use a basket-like thing and then pull it out. That is more difficult rather than using the rigid bronchoscope, where you can use the straight photo. I'm going to show you all the pictures of those instruments that are used in the implementation. Then you will have a better idea of what to do. Okay? So rigid bronchoscopy is the fundamental choice. And if you are going to use rigid bronchoscope, how are you going to ventilate the child? Because it is a rigid tube that will be going into the trachea and to the divisions of trachea. So how will you ventilate a child if a rigid bronchoscope is used?
There will be an oxygen portal will be there, sir.
The what is the technique called? And what
jet
principle is used? Jet ventilation. Okay. And we use what is the principle behind that jet ventilation?
Small volume and a rapid rate, sir.
No, what is? When you use a jet of air, it may entrain a lot of air from the atmosphere. What is the technique called? What is the principle?
Venturi's principle.
Century principle, yes. That is the one word that has to be included in your answer. Now, in cases of foreign body obstruction and airway, retrieval of foreign body. Okay? And there is always a pro and con between spontaneous respiration maintenance and controlled ventilation. So normally we induce the child with inhalation induction, but in an older child you can go for intravenous induction provided the child is hemodynamically stable and then maintain spontaneous ventilation without paralyzing the child so that you can always remove the scope and allow some ventilation to go on. Because once you paralyze the child stops breathing, and if you are not able to ventilate, you will end up in a situation of can't ventilate, can't intubate condition, and we will lose the child. So better to maintain spontaneous respiration and assist the ventilation through jet ventilation using the standard jet ventilator or other modes of ventilation, and maintain anesthesia either by intravenous, total intravenous infusion, and or use oxygen air volatile mixture to maintain the depth of anesthesia required. And spraying the vocal cords and upper trachea before instrumentation is very, very important, because it is a very, very powerful stimulus, especially in a child with a partial breathing and hypoxic state. This instrumentation itself can result in a cardiac arrest. So it is very important that you spray the vocal cords and the upper airway with local anesthetic before stimulation. And once the retrieval is done, then the patient will be immediately regain all the normal parameters, and steroids may be administered to prevent postoperative edema. If there is a delay in retrieval and child has been struggling with a partial obstruction for a longer duration, say 4 to 6 hours, then it may develop a post foreign body removal edema, which will include the passage again. So free of steroid IV administration helps in preventing this particular complication. And with regard to the caudal epidural, you mentioned about all the anatomy and other things. Why caudal epidural is not usually done for adults? Why do you prefer it only in children? Can you do caudal in an adult?
Sacrum will be fused in
Yes,
after
sir.
25 years, sir.
Huh?
Yes.
Landmarks
Fusion of
are
the
more
sacrum.
difficult, isn't it? Adult
Yes,
compared
sir.
to children, you cannot feel the sacral carnua and all those things that easily. Even in a child who is very chubby, it is very difficult to find out. And did you mention anything about the ultrasound usage for caudal identification?
No, sir.
You have to mention the various techniques or methods of identifying the caudal epidural space. The earliest method was anatomical landmark technique,
Yes.
as you rightly said about the triangle formed by the two posterior to inferior iliac spines combining at the joining at the caudal the sacral hiatus. And that was the old method. And patient position has to be described. That can be done in lateral as well as in the prone position. And the usage of ultrasound is now recommended for identification of the heterococcygeal ligament and then the needle technique. What is the difference between ultrasound guided and ultrasound assisted method of local anesthesia? When will you say a local anesthetic technique is ultrasound assisted? When will you say a local anesthetic technique is ultrasound guided? Okay, that's a homework for you. Try to find out. I just want to share my slide because you are on duty. I don't want to hold you up for a long time.